All right. Thanks everyone for being here for Department of Medicine Grand Rounds. We are very excited today to showcase one of our own, Dr. Eli Wilber, who is an assistant professor of medicine in the Division of Infectious Diseases at the Emory University School of Medicine. His scholarly work focuses on the application of the principles of diagnostic stewardship to ensure that patients have access to appropriate testing to inform appropriate patient care. Thank you for being here, Dr. Wilber.
All right. Thank you so much for having me. My name's Eli, and I'm going to talk to you guys today about diagnostic stewardship. So, real quick, I have some disclosures. I've been a content author for Elsevier's clinical key product, and then I have also received an honorarium from Roche Diagnostics for speaking related to my research on blood culture diagnostics, neither of which are going to be the focus of the conversation today. I do, though, want to highlight that I am absolutely willing to use pictures of my children to make you like me and pay attention to what I have to say. So we've got Isaac over here celebrating his first birthday, and then Maya in one of her school photos from this year. So our objectives today, we're going to define diagnostic stewardship. We're going to outline a framework of the diagnostic testing pathway. And we're going to compare gatekeeper and gateway models of diagnostic testing restrictions. So to get us started, let's talk about what is diagnostic stewardship. This is a definition coming from a JAMA viewpoint from 2017 by Dan Morgan, who's one of the leaders in this field. And he describes diagnostic stewardship as involving or modifying the process of ordering, performing, and reporting diagnostic tests to improve the treatment of infections and other conditions. This definition is usable, and I find it helpful to instead analogize to a field with which I think we are all a lot more familiar, and that is antimicrobial stewardship. In antimicrobial stewardship, there's this concept of the 5 rights, the right patient, the right drug, the right dose, the right time, and the right duration. And if you translate that from antimicrobials to diagnostics, what you get is the idea of using the right test on the right patient for the right indication and trying to use the result of that test to promote the right action, whether or not that's additional diagnostic testing or some therapeutic maneuver. Now, in contrast to antimicrobial stewardship, where the role of infectious diseases experts is obvious, it's not immediately clear why ID would also lead a field that purports to examine and improve all of diagnostic testing. But there are some valid reasons why ID providers have emerged as leaders in this field. And the first is diagnostic stewardship is upstream of antibiotic stewardship. In most instances, the decision to test for an infectious disease happens before the decision to treat, or at least before the decision to continue treatment for an infectious syndrome. And to explore this concept a little bit more, we're going to look at a study from the Michigan Hospital Medicine Safety Consortium. So this is a group of acute care hospitals in the state of Michigan. And at the time of this study, 54% of all Michigan hospitals were participating. And this group had the goal of looking at treatment of asymptomatic bacteria. And in their data set, they were sampling all admitted patients with positive urine cultures. And someone with a positive urine culture can either have a true urinary tract infection or they can have asymptomatic bacteria. And then those patients with asymptomatic bacteria can either get treated with antibiotics or they can not be treated with antibiotics. And the antimicrobial stewardship outcome of interest here is the proportion of patients with asymptomatic bacteria that are being treated with antibiotics anyway, right? Because those people are not going to derive any benefit. They're going to be exposed to the potential harms of unnecessary treatment, and you're going to foster the development of antimicrobial resistance and make taking care of that patient in the future, as well as other patients, more difficult. So if you were trying to improve, improve outcomes and decrease the rate at which patients with asymptomatic bacteria are being treated with antibiotics, you might design an antimicrobial stewardship intervention. And that antimicrobial stewardship intervention is probably going to be focused on identifying patients with asymptomatic bacteria and not giving them antibiotics. Conversely, if you try to intervene on this process at the level of the diagnostic testing and you do a diagnostic stewardship intervention, you're going to be trying to identify those patients with asymptomatic bacteria earlier on in the process and never send a urine culture on them in the first place. So here, again, diagnostic stewardship is upstream of antimicrobial stewardship. So thinking forward to what you might observe if an antimicrobial stewardship intervention was successful, you're not going to change the absolute number or percentage of positive urine cultures. You're not going to change the number of UTI cases you observe or even the number of asymptomatic bacteria cases that you observe. What you're hoping for with an antimicrobial stewardship intervention is to decrease the number and the percentage of asymptomatic bacteria patients who receive antibiotics. Conversely, if you have a successful diagnostic stewardship intervention, you're going to decrease the total number of urine cultures collected and consequently, the number of positive urine cultures. The percentage of your positive urine cultures that are true UTIs should go up. The percentage of positive urine cultures that are asymptomatic bacteria should go down, and you're going to decrease the number of patients with asymptomatic bacteria that are being treated, but probably not the percentage of those patients. And so if you have access to half of all hospitalized patients in the state of Michigan, and you look at their data over 3 years, what do you see? And what you see is that the percentage of positive urine cultures that are adjudicated to be true UTIs goes up over time, and the percentage of patients with asymptomatic bacteria who receive antibiotics remains stable over the course of the study period. In other words, what you see is, decrease in urine cultures, increase in true UTI percentage, and no difference in the rate at which patients with asymptomatic bacteria are being treated. So the outcome of interest, the decrease in patients with asymptomatic bacteria being treated, is being driven by the diagnostic stewardship outcome, not by the by the diagnostic stewardship intervention, not the antimicrobial stewardship intervention. So that's all well and good. Another reason why ID experts are so involved in diagnostic stewardship is because of money, right? And so all of our healthcare systems are required to keep track of the rate of healthcare-associated infections. The ones that I think that we're most familiar with are central line-associated bloodstream infections, catheter-associated urinary tract infections, and healthcare onset C. difficile infections. We have to keep track of the rate at which these things occur in our healthcare systems and compare that to the expected rate. And if we have too many cases, our hospitals are at risk for a reduction in Medicare payments if that rate is too high. And so because of that, there's a lot of interest in studying these events and how we can decrease them, the rate at which they occur. And obviously, for each of the three that I mentioned, diagnostics play a key role. You can't have a central line associated bloodstream infection without a blood culture. You can't have a CAUTI without a urine culture, and you can't have a C. diff infection without a C. diff test. So based on this interest in diagnostic stewardship, the Society for Healthcare Epidemiology of America created a diagnostic stewardship task force, which has published a series of papers, the most useful of which I think is this Principles of Diagnostic Stewardship position paper that came out in 2023. And I think the big takeaway from this paper is this framework of organizing the diagnostic process into 5 steps. So the diagnostic process or the diagnostic pathway starts with the clinician testing decision interpretation. So this is when the clinician synthesizes all of the available information about a patient and makes a decision that additional diagnostic testing is necessary. Then that decision is translated into an order. And in the modern healthcare context, that order lives in the electronic healthcare record. That order then leads to the collection of a specimen, and that specimen moves somewhere through the physical healthcare environment. Then there's the actual performing of the test itself in the lab. And then finally, the result of that test has to be communicated back to the provider. And then the process sort of starts anew. Is there enough information to make a treatment decision, or does additional diagnostic testing needed? I like this framework for a lot of reasons. One is it draws our eyes to the clinician up at the top. And it also reminds me of an iceberg, right? The clinician's testing and treatment decisions are what are visible to us. We think about, why was this test ordered? Why is this patient on antibiotics? But we don't think as much about the underlying causes of those testing and treatment decisions. All right. So breaking it down to how we would think about potentially intervening on these different parts of the diagnostic pathway, or the idea, the action, you're talking about changing a provider's diagnostic or management schema. And here, your mechanism of intervention is going to be clinician education, or perhaps designing or fostering the adoption of practice pathways, clinical algorithms. If you're trying to change the ordering step in the process, well, orders live in the electronic healthcare record, so you're going to have to change the EHR. If you want to change the specimen, specimens are collected by people using different tools or devices. And so you can either try to train those people to collect specimens in a different way, or you can change the tool or the device that you're using to collect that specimen. When we think about tests, the tests themselves, so those tests can be performed with a variety of different platforms, reagents, and protocols. So you might change to a different testing platform, or build a testing algorithm where you perform the steps of a diagnostic test in a different way. And then finally, for the results live in the electronic healthcare record. And so you're going to change the EHR there to sort of intervene on that part of the diagnostic pathway. So let's start at the tip of the iceberg and talk about clinician testing decisions and interpretation. So I think the natural place to start here is with ABIM's Choosing Wisely campaign, which came out in 2012. And so the Choosing Wisely campaign was this initiative by ABIM to have subspecialty societies identify practices that were common in their sort of realm of expertise that were thought to be low value, and to develop initiatives to make people more aware of this low value care and find ways to decrease it over time. And it was, it got a ton of press. And if you look on the Choosing Wisely website now, they'll highlight that dozens and dozens of American medical societies published lots of different recommendations about low value care within their domains of expertise, and that there were many other nations whose own medical societies adopted the concepts of the Choosing Wisely campaign, and even used Choosing Wisely branding to try and improve the quality of care in their countries. But I think it's really telling that when you go to the ABIM website, what they brag about is how much press the Choosing Wisely campaign got. And I think you would be really hard pressed to argue that we have turned the corner on overuse or equity in the US healthcare system. And to be clear, there are plenty of other people who are more critical of the Choosing Wisely campaign and its abilities to have actually affected change. One of the more comprehensive reviews was this systematic review by Cliff et al. That came out in 2021. And they looked at the percentage of Choosing Wisely projects that achieved their intended results. And it's above 50%, barely. But what I think is most telling is that when you subdivide the Choosing Wisely campaign projects by their chosen methodology, what you find is that those projects that relied solely on information delivery of communicating recommendations to clinicians almost never worked. And in contrast, projects that incorporated some level of system change were much more likely to be successful. Still, only around 60% or so, but much more successful than those that relied solely on information sharing. And I think, this highlights that doing the right thing can be hard. And I also want to, bring up this quote that came about in the context of a discussion between, to highlight how doing the right thing can be hard. I want to bring up this quote that came up in the context of a discussion about the overuse of diagnostic imaging, particular CT scans in the emergency room setting. And it says that, never underestimate the amount of other people's money that I will spend to keep myself out of court and my own family's future secure and my own career more enjoyable with fewer patient complaints. And I find this quote impactful, not because I think that every case of diagnostic test misuse is the result of defensive medicine. I do not. Although there are certainly times where I think defensive medicine plays a role. Rather, it anchors me to the idea that the default setting of our healthcare system is a trend towards overuse. And so any effort to affect change has to overcome the circumstances that construct the current paradigm. Additionally, I think this quote highlights that cost-based arguments are inherently limited when trying to affect change with frontline providers. Those costs don't really impact the frontline provider in any meaningful way. And even if you are very well-intentioned and care very much about the potential financial toxicity to your patients, the way our healthcare system is set up, it's incredibly opaque how your decisions as in terms of ordering diagnostic testing are going to impact your patient and what the true cost and burden to that patient will be. So if we are going to be impactful in changing the way that we approach diagnostic testing, we need to look beyond the clinician's decision-making process and go beneath the surface and tackle the hidden part of the iceberg. So let's talk about how we order tests. Okay. So I told you at the beginning that I promised you pictures of my children to keep you interested, and I haven't delivered. But here we're going to get some help from Maya. So here's Maya. We're grocery shopping at the DeKalb Farmers Market. She loves it. She's got her Chum Chum in one hand and what looks like a chocolate chip banana muffin in the other. She's living her best life. DeKalb Farmers Market, lots of fun. Kroger, on the other hand, does not make life easy. And the reason Kroger is hard is that up here, way out of, where she can reach or where she can see things are boring things like toothpicks. And right in front of her face are sprinkles, pink sprinkles, rainbow sprinkles, things that are incredibly hard to just walk past when you're 3 years old. And why are the things that she wants right in front of her face? It's not an accident, right? And it's not just for kids. Supermarket stores put the things that they want us to buy in physical locations that are going to catch our eye, and because they know that makes us more likely to purchase them and to choose them. And I want to convince you that all of our medical training does not immunize us against this phenomenon. And to do that, we're going to talk about HIV nucleic acid testing. So when we do HIV nucleic acid testing, there's two possible tests that you can use, an HIV RNA PCR and an HIV DNA PCR. For an HIV RNA PCR, this is a quantitative test. We sometimes call it the viral load. It's used frequently in the routine management of people living with HIV, and it's performed on site. We do it at all of our hospitals. HIV DNA PCR, by contrast, is a qualitative test. It's used in the evaluation of perinatal transmission or rarely in the evaluation of a diagnostic dilemma for an adult patient. It's a send out to our reference lab. It's expensive. And I think even more importantly is it's not just a more expensive substitute. It's worthless in the routine management of someone living with HIV. So it cannot be used in replacement of a viral load. So here is if you typed HIV viral load into Grady's order entry test over the years, this is what would pop up. HIV is shown as a result when viral load is searched, even though that's not what the test does. The test name falsely contains the phrase viral load. And because the computer defaults the results to alphabetical order and D comes before R, it shows you the HIV DNA as the first result for the test. It's kind of hard to imagine how we could set ourselves up for failure more with the way that this is constructed. And sure enough, what you see is that over a 7-year period, we continue to order the test multiple times per week on adult patients at the cost of tens of thousands of dollars per year. So what could you do about this without trying to tell providers to choose the right test? Well, what you can do is you can remove that standalone HIV DNA PCR entirely. You can bury it in an order panel that contains some educating language, but also requires people to acknowledge that they're ordering this specific test. Requires a speed bump. You don't prevent them from doing it completely. You just slow them down, make them think for a second, and see what happens. And if you make it harder to do the wrong thing, people do the wrong thing less. And so what you see here is that the rate of ordering this test in the pediatric population stays unchanged, whereas the rate in the adult population essentially goes to zero. And that change, it averages out to $26,000 a year from making one small change in the electronic healthcare record for one test. And $26,000 a year is not going to be the determining factor in whether or not Grady keeps its doors open, but that is the significant portion of a lab tech's salary. And I can tell you that as we continue to have increasing constraints on staffing and healthcare costs, being able to help the lab's bottom line is really impactful, is incredibly impactful. Okay. So maybe you're a little bit skeptical. That seems like an odd case. The test was called the wrong thing. We were talking about the alphabetical order and the way things were displayed. I need more examples. So let's go across town. Let's go to Emory, and let's talk about blood cultures. Some of you will recognize this interface from Cerner, which was our precursor to Epic. This is what happens if you search for blood cultures. And at the top, you have the sort of standard bacterial blood cultures that we send routinely on patients where we're concerned for bloodstream infection. And at the bottom, you have this area called additional blood cultures that contained, among other things, blood cultures for fungal organisms and for acid-fast bacilli, so AFB blood cultures. And when we made the switch to Epic on October 1st, 2022, the default in the new system was that if you search for blood cultures, all you got was blood culture. You had to go searching a little bit deeper to find the blood cultures for fungal organisms and AFB blood cultures. This was not an intentional decision. This is just, a default setting in the new electronic healthcare record. And so the hypothesis here is that the EHR change is going to lead to a decrease in use of those fungal and AFB blood cultures. And sure enough, that is what we see. So if you look at just simple summary statistics in the pre and post era, there's a 41% reduction in the culturing rate of AFB blood cultures. And if you do a more sophisticated analysis using an interrupted time series to try and understand whether or not the change in electronic healthcare records is responsible for the observed difference in culture rates, you see a pretty strong trend suggesting that that is the case. Looking at fungal blood cultures, you see the exact same thing, that there's an over 50% reduction in the rate that fungal blood cultures are ordered after we make the switch to Epic. And that if you do the interrupted time series analysis, you see, again, strong evidence that the change was because of the change in the electronic healthcare record. And you can do a sensitivity, a sort of a safety analysis and see that there wasn't really any change in the positivity rates for AFB or fungal blood cultures in the pre and post. So what I want you to leave this section of the talk with is the understanding that misuse of different ID diagnostics in two different healthcare systems could be attributed to the design of the electronic healthcare record. That we could fix that misuse by making a change in the EHR without doing anything to teach anybody about what they were doing wrong in the first place. You didn't have to change the provider at all. All you had to do was change the environment in which the provider was practicing. And what I think the key or the conclusion from all of that is that people are not trying to do the wrong thing. They're just responding to the environment in which we place them. But I think there are some instances where people are trying to do the wrong thing, right? And so I think when people are trying to do the wrong thing, we have to think about ways where if someone is going to order a test, we have to think about ways to stop a harmful result from reaching the patient. So here, I want to talk a little bit about the best ways to restrict diagnostic testing. And the sort of the model or the framework for thinking about the restrictions of diagnostic testing is a gatekeeper versus a gateway. In a gatekeeper model, test ordering is restricted to individuals or individual service lines. A good example of this is something like 16S RNA sequencing or other sort of advanced molecular or sequencing-based diagnostic tests. Advantages of a gatekeeper model is that you have a high degree of control over each test that is being sent. It also allows for a nuance and a case-by-case based approach. The disadvantage is that it can be highly variable and personal. You might get more access to diagnostic testing if you know the gatekeeper than by someone who doesn't know who the person who's gatekeeping this test. And because it requires one-on-one conversations in a case-by-case based approach, it's really difficult to scale this across an entire healthcare system or to provide coverage over all times of day, all days of the week. And as a result, gatekeeper-based models are typically only applied to very rare or to very specific instances where the test is either very expensive or has a high chance of causing harm to the patient. Let's contrast that with a gateway-based approach. Here, test approval is based upon predefined criteria. And a good example of this is a reflex urine culture algorithm, which we'll explore more in a minute. An advantage of a gateway-based approach is that it's consistent, it's impersonal, and it's really easy to automate and scale. The disadvantages of a gateway is that it requires a lot more work on the front end. You have to design the algorithm, you have to be able to build it into your electronic healthcare record and have the IT and lab expertise in order to do those things. You also have to have the ability to bypass the gateway when you have patients who don't sort of meet the criteria that you think that you use to just sort of design the logic to create it in the first place. So let's use a urine culture reflex algorithm to explore this a little bit. So instead of ordering a urine culture and have that urine specimen go directly to culture, you can instead have an intermediary step where a urine microscopy is done first. And if there's more than 10 white blood cells per high-powered field, you then allow the urine culture to go forward. Whereas if the urine culture does not have pyuria, there's no white blood cells, then you discard that urine specimen. And then you can have, a separate pathway where you allow patients who you might want to send a urine culture no matter what to bypass this gateway and get a urine culture no matter what, with pregnant patients being a good example of this. And I should point out that at Emory Healthcare, they've recently, narrowed the gateway, I guess is one way of saying, but going from a cutoff of 10 white blood cells to 20. All right, so gateways are really effective. So this is local data from Emory Healthcare, published by Jess Howard Anderson, who's one of our ID faculty, looking at the ordering rate of urine cultures before and after implementing that 10 white blood cell cutoff reflex algorithm back in 2017. And what you see is an abrupt drop in the rate of urine cultures. And again, this kind of makes sense, right? I showed you that data from Michigan at the beginning where diagnostic stewardship algorithms were incredibly impactful in decreasing the number of urine cultures. And it also had those downstream effects where we were able to decrease the the number of patients with asymptomatic bacteria who were being exposed to antimicrobial therapy. All right, so now I want to talk a little bit more about gateways, give you some examples of gateways that are currently in place here at Grady. So at Grady, we have the meningitis encephalitis panel that tests for 14 different causes of community-acquired meningitis or encephalitis. And we let anybody order this test, but the lab is only going to process it if the CSF white blood cell count is greater than or equal to 5, because we have great data showing that if you don't have those white blood cells in the CSF, the chances of that test being positive are exceptionally low. So this, I think, is a really good example of a gateway because lumbar puncture for someone with a concern for infectious meningitis or encephalitis is absolutely a procedure that happens in the middle of the night. And I don't want to be, as the ID, fellow or ID attending, I do not want to be woken up at 3 a.m. to decide whether or not you should be allowed to order this test. I'd much rather have, a system like this where you order it and then based off some predefined criteria, the test either moves forward or does not once the sample reaches the lab. We also have a multiplex diarrheal panel where here, again, we allow anybody to order it, but the test is restricted as to whether or not there's been documentation of the patient having diarrhea in the chart. And then finally, it being flu season and all, I think it's worth highlighting that we also have restrictions around the upper respiratory pathogen panel. So this is a test that tests for some bacterial causes of upper respiratory tract infection, but predominantly tests for an extended suite of respiratory viruses. And we now have, logic in the system that prevents you from ordering this test if the patient is already known to have influenza, RSV, or COVID-19. So at this point, I've made some progress on convincing you that diagnostic stewardship techniques can be really useful to rein in diagnostic testing. And I think it's critically important to also convey that we can use diagnostic stewardship approaches to make diagnoses better and not just more efficient. I think there's a lot of there's concern, I think, in the antimicrobial stewardship community about being viewed as the antibiotic police and just always being telling people no, you can't do that. And I think that in diagnostic stewardship there's a real effort to not let that be sort of the way the field is painted and to emphasize how we can make diagnosis better. So we're going to now do two, again, local examples of how we've applied diagnostic stewardship methodologies to make diagnostic testing better. We'll start with HIV testing. So this is the current HIV testing algorithm at both Emory Healthcare and Grady. An initial specimen the initial specimen is screened for HIV with a combination antigen and antibody screen. If negative, the algorithm stops. If positive, we then do something that's called a differentiation assay or a confirmatory test. If positive, that patient has HIV, and we try to link them to care and get them on therapy. If that differentiation assay is negative, well, then this person is what we call serodiscordant. And that means they could either have acute HIV or have a false positive initial screen. Excuse me. And we need to do an HIV PCR test in order to differentiate acute HIV versus false positive. And to do that HIV PCR test, we need a new specimen. And as you might imagine, anytime you need to bring a patient back and get a second specimen, you've got the chances for someone to fall through the cracks. So this is, again, drawing upon 11 years of data from Grady. What we see is that we have a bar graph that shows the number of outreaches required to resolve a patient's serodiscordant HIV status. 0 outreaches typically means the patient was admitted at the time of the initial testing, and they received a final diagnosis they received a final diagnosis during that index hospitalization and didn't require a second visit. And what you see is that we sort of, no matter how many times we bring people back, we sort of hit this plateau at 25%. 25% of people with serodiscordant results were never able to have a final confirmatory test to resolve their HIV serodiscordant status. And for those that we were able to confirm, there were often substantial delays in getting them the diagnosis. So for people with acute HIV, the median time to confirmation was 7 days. It was almost a month for the people in the false positive group. And again, for the acute HIV group, around 40% of people took 30 days or longer or were never resolved. Thank you. And so what I think this highlights is that the current algorithm is failing a certain group of our patients. And so if we want to think about how we can improve this, we need to think about where in this diagnostic testing framework we can make a change. And so here, the issue really seems to be at the level of the test processing. So what's coming in the future to us at Grady is a new algorithm where after that initial positive HIV screen, we're going to be able to perform a differentiation assay and a qualitative HIV RNA PCR on that primary specimen. And what that means is that we'll be able to determine which of these 4 true outcomes the patient has without having to call them back. So if both the differentiation assay and the HIV qualitative PCR are positive, then that means the patient has HIV. If the differentiation assay is positive, but the PCR is negative, well, that means that they either have HIV-2, which is very rare in the United States, or they have HIV-1 and they have a suppressed viral load, most likely because they're taking ARVs, or because they might be a part of a rare group of individuals who are able to suppress the viral load on their own. People who have a negative differentiation assay but a positive PCR, that's that population with acute HIV. And again, if both those tests are negative, that means they had a false positive screen. All right. So now, one thing I hope that you leave today here, I hope you leave today's talk with, is that the EHR sits at the center of all of this. It is the conduit by which clinicians' ideas are transformed into orders, those orders into tests, and those tests into results. So I want to take another instance of using the EHR to sort of leverage and multiply the effects of diagnostic stewardship. And to do that, let's look at syphilis testing. So for syphilis testing, we have 2 sort of families of tests. We have non-treponemal testing, exemplified by the RPR, and we have treponemal testing, which is exemplified by syphilis antibodies. So RPR is semi-quantitative. It's reported as a titer. Titers decrease with treatment and or time. They can revert to undetectable. They increase with reinfection, and they have an appreciable rate of false positives. Conversely, syphilis antibodies are qualitative. They turn positive very early on in infection. They remain positive for the patient's lifetime, and they cannot be used to diagnose reinfection. And there's fewer false positives. We use these tests together to diagnose someone with syphilis. In the traditional algorithm, we start with the RPR, and then if it's positive, we use a syphilis antibody test to help us decide whether or not that RPR was a false positive. In what's called the reverse algorithm, we start with the syphilis antibody test, and if that's positive, indicating that they've had syphilis at some point in their lifetime, we use the RPR and its titer to help us decide if it's an active syphilis infection or if they've just had syphilis at some point in their past and have treated. Historical practice at Grady and Emory Healthcare has been the traditional algorithm where the RPR comes first. Historical practice at the Atlanta VA is the reverse algorithm. Here is a graph of RPRs processed monthly at the Midtown lab. And you might look at this and say, great, we're screening more people for syphilis. That's a good thing. And I think that is true in a sense. But at Midtown, RPRs have to be processed by hand. And each test costs you 12 minutes of a lab tech's time. And so when you see a 30, 40, almost 50% increase in the monthly burden of this lab testing, that's a lot of hours every single day that someone is doing something that they weren't doing before. And we do not operate at that kind of margin of person power in the current healthcare system, and certainly not in the post-COVID world. And so if you're looking at this graph, you might say, okay, well, why are things going up in this way? And it looks like something sort of happened in the summer of 2023, where we kind of took a big step up. And that's when Georgia Senate Bill 46 came into effect. And Georgia Senate Bill 46 says that all pregnant persons, when they present in labor, have to be tested for syphilis, regardless of whether or not they've had a previous testing during that pregnancy. So everyone admitted to labor and delivery has to have a syphilis test at that time. So if you drill down into our data at Midtown, you see that 79% of our RPRs are coming from labor and delivery and the emergency department. And then, the other 21% come from other parts of the hospital. So if you're trying to think about how to decrease the burden in the lab, maybe what you could do is try to take that testing volume, that bulk of the testing volume, and move them from the manual test first to the automated test first. And the advantage to doing that, rather than trying to shift the entire hospital over, there's a much smaller group of providers that I have to go and teach how to interpret the reverse algorithm to, because there are nuances to it, right? Because the first test is going to be positive a lot more often because it's going to be positive for anyone who's ever had syphilis before in their life. And so you have to teach people to interpret the results a different way. And if you try to teach an entire hospital, that can be challenging. But if you just tell me I only have to teach one group of providers who are highly motivated, then I think you can be a lot more successful. So that's what we tried to do. And what you see is that when we put that intervention into place, the number of RPRs performed by the Midtown lab decreases precipitously. And that if you then look to see, where is that reduction coming from, see that there's no change in the non-L&D and ED parts of the hospital, but there's a big drop in the L&D and ED. So we're able to have the impact that we wanted to. Okay. So we're all tired. You guys had to hear me cough a lot. Let's bring this home. So the big take-home points I want you to have. Diagnostic stewardship is the iterative science of improving diagnostic test use. Right test, right patient promotes the right action. Diagnostic test misuse is often unintentional and can be prevented with intentional design of the EHR interface. Gateway-based restrictions are an effective and promising approach for scaling diagnostic stewardship. And I promise I'm not an epic apologist, but we do live in an EHR ecosystem. It's not going to go away. We should take advantage of it and leverage it to help us provide better care. And then one last thing I'll harp on is clearly, I think a lot of things are changing about our, healthcare and regulatory climate. But this was a joint initiative of the CDC, the AHRQ, and CMS that came out in fall of 2024, which was launching this idea of hospital diagnostic excellence programs. The idea that similar to how we've created programs around optimizing the use of antimicrobials through antimicrobial stewardship programs, which are now mandated by CMS, that we should be moving towards having the same approach to diagnostic excellence. And hospitals should have programs that routinely analyze and seek to improve the diagnostic processes and the use of diagnostic testing in that healthcare setting. So I think that this will, maybe make, I think it remains to be seen how this will change in the current climate, but I think this is the direction in which, the field is moving. Additionally, there's been a concerted effort to intentionally expand diagnostic stewardship beyond just the field of infectious diseases. There's this article from the Journal of Hospital Medicine outlining, specific other examples for common clinical conditions where diagnostic stewardship methodologies could be applied to improve patient care. And I think Dr. Vaughn actually gave hospital medicine grand rounds at Emory Decatur sometime in the last year. All right. So clearly I talked to you about a lot of different work here at Emory and Grady, and none of that would be possible without the army of people that you see here up on the slide, as well as many people who I'm sure I left out. So I cannot be more appreciative for these people for supporting me in my training and supporting this work as I try to get it moving at both healthcare systems. And with that, I think we will have some time for some questions.
Thank you, Eli. That was an incredible talk, and I think probably resonated with many of us in the audience. Uh, we have one question, it looks like. Clearly, diagnostic stewardship improves care and outcomes, but I think the communication with providers remains the missing piece. The reverse syphilis testing education experience is a great example. The ANA test changes a decade ago are another example. In both examples, communication was a huge piece, slash, missing piece. But also, what options do we have to create a bidirectional dialogue to improve engagement and understanding?
Yeah, I think that's a great question. I think there's nothing more disconcerting than showing up to work someday and finding that something that you relied upon or was part of your routine practice is all of a sudden different. I think we all experienced that with UpToDate in the last like couple of weeks. Um, and I think that I, I think I think two ways to think about it. Like one is to try and make sure that you're being very intentional about your communication and trying to reach as many stakeholders as before you implement a change. And the other is to try and find ways to build interpretation for your change into the change itself. And so what I mean by that is, or an example of that is what we did with the HIV DNA PCR order at Grady, where when you get to the order, there is a very tight and small explanation of, why things are different and why we want you to be sort of doing things differently. And there's, I think, good evidence from the clinical decision support literature that BPAs that are able to effectively communicate why the BPA is fired and what the sort of rationale behind it is in a very concise format are acted upon in the correct direction much more often than decision support tools that do not. Yeah, we have a question in the room. Okay.
Thank you for a great presentation. My heart for sure. My question is that it seems like some of the choices, they're squeaky wheels. Somebody calls and complains, oh, we have all this RPR testing, what do we do? And you address that. But is there a proactive and systematic way to identify opportunities to decrease waste or overuse or misuse?
Yeah, so the question was, it seems like some of these examples are instances where a squeaky wheel reported a problem and then you design a solution and you fix it. Is there a more systematic way to identify targets for diagnostic stewardship interventions? And I think that there's that's sort of like what I think the CDC and CMS and AHRQ were talking about with these diagnostic excellence programs is we should be creating communities of content matter experts, clinicians, laboratorians, radiologists, to identify at a system level what are the pain points in our diagnostic pathway, where are places where we are prone for making the wrong diagnosis or ordering the wrong test, and then designing solutions that focus on those high priority pieces that help with prioritization. So I think that's a big part of having a formal diagnostic excellence program is a way to prioritize problems. The other thing that you can do now is that I think the electronic healthcare record can help you with is it can just help you have the data, right? So you can help you understand like, well, how many times do we order this test? So you can help you look at, if you want send out testing is I think a big target because it's costly and it's just more complicated. You can really easily extract like what tests do we send out at what rate, and then look at the top 5 and think, are we using these 5 appropriately? And then move through those and then move on to the next 5 and just kind of work your way through that work queue would be one way to look at things. We have one more question in the room.
So I think to your point, bringing up that there are different processes that happen at hospitals. I was wondering if there's a way that we reach, a lot of the folks listening traveling between sites. Is there a way to think that that's each site and try and standardize it across our system?
Yeah, so the question was about, we in our training programs, but also our faculty, we have lots of people who practice at multiple sites, and including in multiple institutions, Emory Healthcare, Grady, the VA. And is there a way to leverage best practices from one institution and apply those to others? I think certainly at like commit, like sort of like a organizational standpoint, I think so. I think you could take the same processes of like, how do you analyze diagnostic testing? How do you prioritize things? How do you design and implement change? That should be able to map to each institution. Specific interventions may vary, right? Because some of it may depend on literally the hardware in the lab. Like the RPR example, like that project is specific to Midtown. You know, a lot of our other sites do RPRs on the automated machine, and that's just not what Midtown has. And there's some capital and physical space constraints that make that the way it is. So I think specific projects may not be able to map from one facility to another all the time, but certainly the concept of having a structured way of reviewing diagnostic testing and trying to improve it is something that all of our sites could do and could learn from each other. And I think there's also, again, being a site where we have so much interchange of providers, I think there's an argument to be made that we should standardize when we can and try to do things the same way, because then I think that will help all of us make better decisions. But standardization is challenging, I'll tell you.
What other questions we have?
We have one more in the room here.
There's an article in the New Journal, $1,200. Paid $20 test because you have these check boxes that are easy to check. You order all of it. And some of these order panels that we have or Walmart functions, it's easy to sort of just check the basics, but it's also, they have a laundry list of things you could also check. And if you're a novice or not familiar with it, maybe it's better to just check, I need Albolase and I need this and that. How do you, on the flip side, if you don't have those things in a panel in one place somewhere, it's cumbersome to go and find and might miss it. So how do you balance those two things about convenience, but also not making the routine complicated?
Yeah, so the question from the room was how basically when you have an order panel, it becomes really easy to over order because lots of orders are presented in front of you. And we saw some examples of that today. But conversely, if you don't conclude things in an order panel, it can be hard to track down individual components, and you may miss like necessary parts of a diagnostic workup. And this is, I think, a situation where, a gateway-based model or reflex model to diagnostic workup can be really impactful. So you can imagine a scenario where you say, okay, I am doing an LP for a presumed infection. If the CFSF white blood cell count is greater than 5, I get this infectious test, this infectious test, this infectious test. That happens next. And you can have logic in the electronic healthcare record that facilitates that happening. Or if you say you're doing an LP out of a concern for, an autoinflammatory syndrome, you could do the same thing where if the protein is above a certain level, then these, autoantibodies get sent off and this antibody panel gets sent off. And I think you could, design various gateways and various logic that allows sort of a reflex model-based approach rather than just trying to have people, click everything at the front end. So I think that sort of, I think that reflex-based approach is probably the best answer to that.
Any other questions in our audience? Dr. Law wants to know, how do we get in touch with our diagnostic stewards if we have questions?
Yeah, great question. So, I think there's a couple of ways to think about that. Don't try to hide. So I do have some, formal role, I think, in both healthcare systems at this point. So I'm happy to be a point of contact, and then based on the subject matter expertise that's necessary, helping you connect with the right person. So thank you, Dr. Law. I appreciate that plug. I can't help you at the VA, but I can help you get in touch with someone who can probably help you. There's a comment in the chart about, or the comment in the chat, asking why have chosen wisely guidelines been taken down? I think the website changed to sort of emphasize more like the holistic, takeaway from the project as opposed to the specific aims. I think some of the specific aims can still be found in publications from the various subspecialty societies or on the subspecialty society websites, but the Choosing Wisely website itself has sort of become more of a simple wrap up, talking about the initiative overall as opposed to talking about the actual details. I think some of it is also like those were designed in like 2012, 2013. I think a lot of them are some of them may no longer reflect best science. All right. Thank you all. And thank you to everyone at Grady for coming out.
All right. Thanks everyone for being here. Please do scan that QR code so you can complete an evaluation for our grand rounds today. And when you complete the evaluation, you will get the code for your See Me this week. Everyone else, have a great rest of your day. Bye, y'all.